Hello everyone, I'm Dr. Prachi Mehrotra. I'm consultant and head of Trauma and Emergency Services, Narayana Hospital, Gurgaon. Today I'll be taking class on antipsychotic poisoning. And as we all know, before knowing what is antipsychotic poisoning and what happens in that, we all know that in overdose, the clinical toxicity is primary and exaggerated effect of the pharmacological activity, right? So first we'll know about the mechanism of action of antipsychotic drugs. So antipsychotics, they are basically divided into like two generations, old generation and new generation. In old generation, we have typical antipsychotic drugs. They are dopamine antagonist. That means they block dopamine receptors in all parts of the brain. Common drugs are chlorpromazine, haloperidol, pimemoside, flufenazine, etc. Now, the other category is atypical antipsychotic drugs. Atypical means it does not block only dopamine receptors, but also it blocks the serotonin receptors. So the first one is dopamine and serotonin antagonist. It blocks dopamine and serotonin receptors in the brain. So common drugs are amisulpride, clozapine, olanzapine, qutipine, etc. The last but not the least, the newer generation, that is partial dopamine antagonist. It only blocks a portion of dopamine receptors in the brain, and it also blocks the serotonin receptors. Example is aripiprazole. So now mechanism of action of antipsychotic drugs are it causes inhibition of alpha adrenergic receptors, dopamine receptors, inhibition of histamine receptors, inhibition of muscarinic receptors. It also causes, as we have already studied, inhibition of serotonin receptors, and it also inhibits sodium, potassium, and calcium channels. So now, when there is antipsychotic medication or drugs, when it blocks dopamine receptors, it causes positive psychotic symptoms. And adverse effects will be extrapyramidal symptoms and increase in prolactin levels. And when it blocks serotonin receptors, it accentuates the extrapyramidal symptoms, it increases the extrapyramidal symptoms, and it has possible role in circadian rhythm and hallucinations. And it also causes anxiety, cognition, and mood disorders. And also thermoregulation and memory and endocrine regulation also affects by the serotonin effect of this antipsychotic drugs. And when it blocks alpha adrenergic receptors, it causes dizziness, drowsiness, and orthostatic hypotension. And when it blocks histamine receptors, it causes sedation, it can cause weight gain, and it also causes impaired cognition. And when it blocks muscarinic receptors, as we all know, it will cause constipation, blurred vision, dry mouth, drowsiness, tachycardia, and urinary retention. So now going into further details like dopaminergic, there are some dopaminergic pathways in the brain which this antipsychotic drugs they block. So let us see those pathways. So when just a minute. Yes, when dopaminergic this pathway when it's a mesocortical pathway, that means it starts from ventral tegmental area, this ventral tegmental area to this prefrontal cortex. This is called mesocortical pathway. The other pathway is mesolimbic pathway. In mesolimbic pathway, there's ventral tegmental area and pathways goes up to nucleus accumbens. So when these dopamine acts on these two pathways, the mesocortical and mesolimbic pathway, it causes antipsychotic efficacy. Okay, and then the other pathway is nigrostriatal pathway. So nigrostriatal pathway is this one. It starts from substantia nigra and ends on basal ganglia. Substantia nigra to basal ganglia. When dopamine receptors they block this pathway, this pathway is called nigrostriatal pathway, And when it blocks this pathway, it causes extrapyramidal side effect. So this nigrostriatal pathway will cause extrapyramidal side effect. The other pathway is tubulo-infundibular pathway, this yellow one. So when it affects this tubulo-infundibular pathway, it causes an increase in prolactin levels. So there will be hyperprolactinemia, galacturia, gynecomastia, and sexual dysfunction. Other than this, when this dopamine receptors, they block anterior hypothalamus, they can cause alternation in body temperature. Okay. And when it blocks area prostrema, it causes antiemetic activity. So based on this mechanism of action and where the dopamine or histamine or muscarinic receptors will act, the clinical effects will be according to that. So now CNS effects will be lethargy, ataxia, dysarthria, confusion to coma, with respiratory depression in case of severe overdose. Now, in case of children, even ingestion of one pill of antipsychotic will have significant CNS depression, whereas in adults, mixed doses will cause this significant CNS effect. Otherwise, if a person takes a few pills of antipsychotics, there's less mortality. So not much morbidity and mortality is seen. Now, other CNS effects are paradoxical agitation and delirium. It again occurs in mixed overdoses, especially the agent which have anti-muscarinic properties. So anti-muscarinic toxicity will be, as we have discussed, tachycardia, dry mucous membrane, dry skin, decreased bowel sounds, urinary retention, agitation, delirium, and hypothermia. Occurs most commonly in clozapine, quetiapine, and thioridazine. It also causes meiosis, and seizure can also occur. Now, the cardiovascular effects will be sinus tachycardia and orthostatic hypotension. Now, ECG changes, two main ECG changes are seen. One is QT prolongation and one is wide QRS complex. So QT prolongation, more than 500. And it is highest rate of QT prolongation is seen as amisulpride and thyroidazine. So, and there may be some non-specific T-wave abnormalities also, and ventricular dysarrhythmia can also occur sometime. And most important, extrapyramidal syndrome can also occur. And in extrapyramidal syndrome, mainly is divided into four extrapyramidal syndrome. First one is acute dystonia, akathisia, drug-induced Parkinsonism, and tardive dyskinesia. Let's see a few lines how to distinguish between these four. Let's see. So this is a pictorial graphical presentation of these symptoms. I know you cannot read it properly, but I have put the slide, so that it can be in your mind that how does a pseudo Parkinsonism look like. Acute pseudo Parkinsonism, there will be stoop posture, stuffing gait, rigidity, bradykinesia could be there. And this is acute dystonia picture. In acute dystonia, what happens? There's a involuntary movement, eye movement, and facial spasm, laryngeal spasm, and muscle spasm are there, mainly in the neck and facial area. Then is akathisia. Akathisia, there will be trouble. The person will have trouble in standing up. And this is tardive dyskinesia picture. Okay, the chewing motion, there will be facial dyskinesia, involuntary movements of the body. So here you can see. In what happens in pseudo-Parkinsonism, there will be tremor, slowness, mask face, gait instability, and cogwheel rigidity. And acute dystonia is severe muscle spasm. Akathisia is inner restlessness. It's also called ants in the pants. You'll not, the person will not be stable, will not be standing still, always moving, and there will be always restlessness. Tardive dyskinesia, there will be uncontrollable muscle movements, mostly affecting the orofacial muscles. Okay. So, when a person or a patient comes to you who has ingested antipsychotic drug, there could be the like a patient is already a psychiatric patient, he's already on antipsychotic drugs, and he has overdosed the medication. The other thing can be patient is a normal person, some person in his family is taking antipsychotic drug, and he has overdosed that. So, when a person comes, mainly about I'm talking about this extrapyramidal symptoms. If the patient is not taking these medication and patient landed up in the emergency within 3 hours, then in terms of extrapyramidal effects, there can be acute dystonia. Bradykinesia or pseudo-Parkinsonism, it develops from 3 days to 3 weeks. Akathisia only develops after 3 months of taking antipsychotic drugs, and tardive dyskinesia can occur when a person takes regular taking those antipsychotic medication for more than 3 years. So you should always keep this mind when this extrapyramidal symptoms can develop. Now, what investigations you'll do for these patients? Basic chemistry test like CBC, LFT, KFT, urine routine. You can get the idea of what drug patient has consumed and in what amount. So, drug of abuse, there's a screening test, 12-panel urine drug test that you can do when patient comes in emergency. Pregnancy test is must for the woman of childbearing age. Test for co-ingestion is also important. It's not the likely that a patient has taken antipsychotic drug, so he'll take only antipsychotic drug. He must have taken some mixed drugs also. So we have to test for co-ingestions, including paracetamol and salicylate. And ECG to assess the conduction defect, wide QRS complex, or QT prolongation, or ventricular arrhythmias. Now, treatment is largely supportive. IV assist, monitor the cardiac rhythm, check blood glucose. Ventilative support is very important in case of respiratory depression. And patients should receive oxygen who are unconscious. Pulse oximetry is important, SpO2, assessment of blood glucose, and consideration of administration of naloxone and thiamine if you have that doubt. Now, seizure should be treated with benzodiazepine like lorazepam. So you can see, basically, it's like a symptomatic treatment as first. And how will you treat hypotension? So if patient is on hypotension, treat hypotension with IV fluid. You can give 1 to 2 liter of crystalloid initially, and then children can receive around 20 to 40 milliliter per kg body weight of fluid. If hypotension persists after even giving 2 liters of crystalloid, you can start on with noradrenaline. Dopamine is usually avoided in antipsychotic drugs. Overdose. Now, what is the role of magnesium? So, patient with QTC prolongation of more than 500 milliseconds, they are at increased risk of developing torsades pointus. Assuming there are no contraindications to magnesium supplementation and regardless of the magnesium level, you don't have to check magnesium level before giving the magnesium sulfate. If QTC interval is more than 500 milliseconds, you have to give magnesium straight away. How you'll give? 2 gram IV over 10 minutes. You can dilute it in 100 ml NS or so, and you can give that over 10 minutes. Now, patient with these are the patient who has not developed torsades de pointus, but QTC interval is more than 500 millisecond. You'll give 2 gram magnesium IV over 10 minutes. If patient has developed torsades de pointus, you have to give this 2 gram IV bolus followed by 2 to 4 milligram per minute infusion, regardless of the magnesium concentration again. And overnight bracing can also be useful, especially in cases that prove refractory to magnesium. Now, arrhythmias treatment, patient with intraventricular conduction defect. It was the previous slide we have seen about QT prolongation. If QRS is prolonged and ventricular dysarrhythmia is there, you can give sodium bicarbonate 1 to 2 milliequivalent per kg IV bolus, and followed by either continuous infusion or boluses, intermittent boluses you can give depending upon the condition of the patient. Lidocaine is also this acceptable alternative for ventricular dysrhythmia. But don't give class 1A, class 1C, class 3 and class 4 antiarrhythmic drug in case of the patient who has cardiac conduction disturbances, who are currently taking an antipsychotic, because these antiarrhythmics, this class 1A, class C, class 3 and class 4 antiarrhythmic, they these arrhythmic can potentiate cardiotoxicity. So we avoid these class 1A, class 1C, 3 and 4 antiarrhythmic in these patients. Now, following injection, you have to observe the patient for 6 hours. If pulse and BP are normal, and in QTC interval prolongation is reduced or come back to normal after 6 hours of observation, pulse and blood pressure are fine. Patient with evidence of toxicity like sinus tachycardia, QT prolongation should be, and they should be monitored in a monitored bed for 6 hours. If after 6 hours also patient has not become stable, or patient develops severe symptoms like seizure, respiratory depression, hypotension, acidosis, then you should admit the patient in ICU. Now, the one more important thing in antipsychotic this overdose is development of Neuroleptic malignant syndrome. So in Neuroleptic, this is the typical feature of the patient who comes to an emergency department with Neuroleptic malignant syndrome. So what will patient have? Patient will have mydriasis, diaphoresis, will be extremely agitated. There will be tachycardia, autonomic instability, clonus will be there, tremor, hyperreflexia, and increased bowel sounds. They would can also have this diarrhea. So this is a typical feature of Neuroleptic malignant syndrome patient. Now, Neuroleptic malignant syndrome patient, this develop over a period of 1 to 3 days. The classical tetrad of Neuroleptic malignant syndrome are altered mental status, muscular rigidity, fever, and sympathetic nervous system stability. So this is the current diagnostic criteria of Neuroleptic malignant syndrome. So there, each criteria is assigned a priority score of total of 100 and cutoff is 74. So your criteria meets at 74, then patient will be having Neuroleptic malignant syndrome. You don't have to remember okay, how many points we have to give and how, but you should know at least these criteria. What are the criteria of Neuroleptic malignant syndrome? So the first one is exposure to dopamine antagonist and dopamine agonist withdrawal in past 72 hours. Hypothermia. So how much will be the temperature? More than 100.4 on at least 2 occasions, not at 1 occasion, 2 occasions. And it has to be measured orally. So oral temperature should be more than 100.4 in 2 separate occasions. Third one is rigidity, development of the rigidity. Then mental status alteration. The next point is elevated creatinine phosphokinase level. How much it should be elevated? At least more than 4 times the upper limit of creatinine phosphokinase. The sympathetic nervous system lability, it is defined as presence of 2 or more of these features. What are these features? Elevated blood pressure, systolic or diastolic, at least 25% of the baseline. Suppose a person's baseline is 120 by 80 or 140 by 90, it has to be 25% more than that baseline. And blood pressure fluctuation, that is very important. Change of 20 mm of diastolic and 20 mm of 25 mm of mercury of systolic in 24 hours. So blood pressure fluctuation either up or down. In 24 hours, if systolic pressure rises by more than 25 mm Hg, or the diastolic pressure falls by 20 mm of Hg, or both or either of those in 24 hours, that is called blood pressure fluctuation. Then there could be diaphoresis and urinary incontinence. So elevated blood pressure fluctuation, diaphoresis, and urine incontinence. Any of these 4, any of the 2 features should be there. Then we'll term it as sympathetic nervous system lability. Then tachycardia. So tachycardia also how much? At least 25% of the baseline. And tachypnea, at least 50% above baseline. And negative workup for infectious, toxic, metabolic, and neurological causes. So why negative workup is essential? Because when patient comes to emergency department, uh, he will not tell you that I am having neuroleptic malignant syndrome. You have to rule out other causes also. You have to come to a diagnosis of neuroleptic malignant syndrome. So negative workup is very important to rule out infectious, toxic, metabolic, or neurologic causes of these clinical features. So laboratory abnormalities could be leukocytosis, elevated levels of hepatic transaminases, hypernatremia or hyponatremia, metabolic acidosis, myoglobinuria, elevated BUN and creatinine levels, and decreased serum iron levels. Now, how will you treat neuroleptic malignant syndrome? First of all, withdraw any antipsychotic or potentiating drugs such as anticholinergic, antihistamine, or lithium. IV hydration is very important. Why IV hydration is important? To circulate the volume and maintain the urine output. Reduce patient's temperature because these patients will be having hypothermia. So you have to cool them down either by giving a cool saline or putting on the fan, taking out all the warm clothes, cold sponging. And you can sedate the patient with benzodiazepine, such as lorazepam, 1 to 2 milligram IV every 2 to 4 hours as needed. And airway protection is also important. The person who is in respiratory distress or not able to, GCS is poor, you have to consider early intubation in these cases, especially if a patient is having hypersalivation because we can aspirate, right? So early intubation is very important. Now, about the medication, you can give non-depolarizing neuromuscular blocking agents like detrorine, bromocriptine, or amantadine. Detrorine, how much you will give? 1 to 2.5 milligram per kg IV. You should remember it's per kg. It's not that you give 1 to 2.5. Depends upon the patient's weight. And bolus, you will give 1 to 2.5 milligram per kg IV, followed by 1 milligram per kg IV every 6 hours. Or you can give bromocriptine starting with 2.5 milligram per hour. So look here, only dantrolene is milligram per kg IV. Otherwise, all others doesn't depend upon the weight. Like bromocriptine, you will give 2.5 milligram per oral 3 to 4 times a day. Or amantadine also you can give orally 100 milligram 3 times a day. So either of the 3 drugs you can give to the patient. That's it. Thank you.